All right, good morning. Thank you for joining us once again at the Department of Medicine's Grand Rounds. On behalf of Dr. Frazier, Costco, Spencer, and myself, we're so glad you're here. Unfortunately, today is the last of our series highlighting our amazing senior residents, but we've got two more fantastic talks today that I'm very excited about. First up, we have Dr. Kevin Garza. Dr. Garza grew up in Dallas, Texas, but has come to call St. Louis home for the past 11 years. During his time here, he graduated with honors from Washington University in St. Louis, went on to receive his medical degree from Washington University School of Medicine. He has an interest in medical education and has contributed to the new Gateway curriculum at our medical school. He's here with us now as a representative from the teaching position pathway. And then after Dr. Garza, we are thrilled to have Dr. Mohammed Ahmed. Dr. Ahmed received his BS with highest honors in biochemistry and biotechnology from Carleton University in Ottawa, before obtaining his MD from Oakland University William Beaumont School of Medicine. He is involved with the Residence Fellows Diversity Initiative here at Barnes and plans to pursue a cardiology fellowship next year. He is an extremely accomplished artist as well, and you can see some of his works at The Artistic Doctor on Instagram. As a reminder, this and all previous talks are available at the Department of Medicine website and are uploaded to our brand new Department of Medicine YouTube channel. So please head over there and check it out if you missed this or you want to review any topics. Once again, we will hear from both speakers and have questions at the very end, but please feel free to send any questions along to me as we go in the chat, and we can address them at the end for both speakers. With that, we will go ahead and have Dr. Garza take it away.
Okay, thank you, John, for the introduction, and thanks to everyone here for giving me the opportunity to speak on medical education within social media. I think I've got my screen shared here, so we'll go ahead and kick this thing off. I have no financial disclosures. During this talk, I want to make sure that everyone has a reasonable understanding of what comprises social media and free open access medical education. I want everyone to appreciate the current landscape of education in social media. And I want to recognize unique characteristics of social media as a tool for med ed and the opportunities that present and some, limitations that we need to keep an eye on. So kick things off, I wanted to help to get a sense of scale regarding social media use in the United States. It's approaching ubiquity right now, with about 80% of US adults using social media since 2017. And then looking at physicians specifically, in a poll conducted last year, 90% of physicians use social media for personal use, while 70% use social media in a professional context. This includes education, networking, promotion of their own projects. So not specifically to education exclusively, but it's still pretty substantial utilization there. And then just another way for us to get a sense of the scale that medical education on social media platforms is, kind of scale of the impact it's giving. I thought Radiopedia really helped to deliver that information. They are very open about their usage analytics. In 2020, Radiopedia served over 200 million pages to over 34 million individuals from every country on earth. Just in 2020, over 5,700 cases were contributed and over 1,300 new articles were written. Graph demonstrates that since mid-2020, they've had steady traffic above 17 million page views per month. Okay, so before getting any further into the talk, we should go ahead and define social media. I think we all have a big gestalt of social media through our experiences on the platforms we can identify as social media. Facebook is where I go to see my siblings post updates on my nieces and where I go to see my uncle's kind of wild political takes. Instagram is where I go to realize all my friends are photographers, artists, and taking much better vacations than I am, etc. But to get a more formal definition, I like how Wikipedia defines social media as a collection of interactive technologies that facilitate the creation and exchange of information and content through virtual networks. And then it goes on to identify some common features of social media, including a predominance of user-generated content. So now that we have social media addressed, I wanted to talk about an important and related topic, free open access medical education, or FOMED. The term was coined in June 2012 during the International Conference on Emergency Medicine. I describe FOAM as a medical education that is available for anyone, anywhere, anytime. It's a dynamic collection of independent resources and tools designed around lifelong learning in medicine. When it was first described in 2012 in the quote that I have on this slide, it, some kind of revolutionary superlative language was used. And while I think it has and continues to bring substantial changes to medical education, it's fair to say that it's seen more frequently now as an essential adjunct to more traditional educational models, rather than a new world order that will replace the old ways. That said, I'm happy to see the spirit of revolution still burn brightly within my resident group chat. Okay, so we understand the two terms now. That's great, because the rest of this talk is going to focus on the proverbial Goldilocks zone or sweet spot in the overlap between social media and FOMED. I think to illustrate this a bit further, it'd be helpful to provide a few examples of free open access education resources that don't have any overlap with social media. The first of which here is the journal Open Medicine, which offers free publication and open access of its articles for readers. What it does not have is a platform for a community of users to self-publish their material and for users to freely discuss the content of the articles. I also wanted to include a shout out to Hyperphysics from Georgia State University and Paul's online math notes from Paul Dawkins at Lamar University, because although they aren't, medical education, they're excellent free open access resources that got me through undergrad physics, calculus, differential equations. So standing in contrast to these resources is Life in the Fast Lane, a blog that provides a platform for users to publish EM, crit care related posts and to comment on the blog posts created by others. So we have an understanding of what FOMED, and social media is. So right now I'd like to go on a really brief stretch describing how medical education looks like on social media. It's diverse. It can take virtually any form of media. And we're just going to run through a few examples of each. Podcasts are ubiquitous. I don't know the last time I've listened to actual music at the gym. Pictured here are a few popular podcasts, some that I like in particular. We've got Clinical Problem Solvers, Flip the Script, and Show Me Curbsiders and Show Me the Science podcast from WashU. Videos are also incredibly common. I don't know that there's anyone here who hasn't watched a video to review steps on performing procedure, the steps of performing procedure prior to going in there. Here we have a screenshot of Dr. Dustin Williams, creator of Online MedEd, in one of his chalk talks on coronary artery disease. Podcasts are also, blogs are also, very common. A lot of examples of this. I chose UCSF's Chief Resident Hub to show a representative example here. And here's an example of them distilling pearls from resident report on a case of herpes encephalitis, so that resident report could be disseminated to a wider audience. Online journal clubs, also incredibly common. I could have filled 4 different slides with different Twitter accounts that host at least a weekly journal club that become a platform for discussion of these articles. Wikis, huge host of information here, include Radiopedia, Wikidoc, WikiEM. And then I wanted to spend a little bit more time on tutorials, as they tend to be more versatile and have a higher degree of engagement. Tutorials are a thread of multiple individual tweets linked together to tell a story that is more complex and can be addressed, that can be addressed in the 240 character limit that Twitter imposes. My first example here is a clinical tutorial designed to teach learners how to distinguish VTAC from supraventricular tachycardia with aberrancy. And in about a 9 tweet session, thread here, he ends up going through Brugada criteria, other things to cue in to give learners an idea of whether they're looking at SVT or VT and the management for each. And then I wanted to provide another example here of a tutorial describing new primary literature. In this case, we have PI Feng Zhang at MIT describing a recent publication from his lab that details a new technology or methodology to deliver RNA intracellularly using retrovirus and mammalian proteins. And his tutorial includes a lot of the actual figures from his paper, as well as a few additional illustrations to convey the technology. All right, and then the last modality is modules, which are admittedly something of a catch-all term, but it's generally used to describe more interactive case-based learning. I think the Sim series is a great example of these modules. They're developed by Dr. Samira Farouk at Mount Sinai. Here we just have a quick sort of layout of their overall design approach to these modules, which give the history, physical data in a very standardized format before it starts asking for users, asking for people interacting with the modules to interact with it, to have some active recall of their own. Okay, and here's an example of how people can interact with these modules, how they can select different options here on this module that was for ulcerative colitis, a case of ulcerative colitis. It gives you the ability to choose what further workup you'd want in this case, and then it gives you rationale for why that selection might be appropriate or inappropriate. So we've established medical education through social media has a diverse set of appearance, but what I'm most interested in really here is identifying distinguishing features of social media, what it brings to the table, how we can leverage these, or what we need to look out for. I think the most significant feature of social media in medical education is its ability to form robust communities. These communities can be incredibly collaborative, as seen in the American Journal of Kidney Disease's annual Neph Madness tournament. It's a competition where different groups compete in a March Madness style tournament to create competing modules or lectures on different hot topics in nephrology. Pictured here is the finals of the 2021 tournament, where a lecture on implantable bioartificial kidneys squared up against dialysis timing in the surgical ICU. Maybe more organically, these communities also facilitate considerable interaction between content creators and their audience. This allows for discussion, critique, expansion, and revision of the original content, effectively accelerating and democratizing a role that would normally be filled by editorials and commentary articles in medical journals. So this is a callback to one of the online MedEd screenshots I shared earlier on that chalk talk on coronary artery disease. There are a few hundred comments on these videos in which audience asked for a clarification on some of the content. They might have challenged the information that's presented in the video, and they expanded the discussion beyond the original scope that was presented in the video. The creator of that content, Dr. Dustin Williams, is prolific through the comment sections of all of his videos and addresses the majority of comments that are sent his way. If we see the end content of these modules that are posted on social media, not only as the original content that was posted, but the corpus of comments associated with it, then the product remains a living document that undergoes repeated revision, expansion, and refinement for as long as the community continues to engage with it. And we just have further examples of this on the following slides. Here's someone trying to give a summative statement on the chalk talk that Dr. Williams adds some nuance to. And here he makes a major addendum that he pins to the top of the comment section in response to many audience members that objected to him equivocating left bundle branch block to STEMIs. So we can also see a good amount of the benefit of community engagement in some examples from the tutorials that I had shown you before. So here is a response to the tutorial on the differentiation of SVT with aberrancy and ventricular tachycardia. This retweet from Dr. Reimagining boosted the post and spread its impact, and also added a really important and I think very helpful visual aid reinforcing the points made in the tutorial, making the content more digestible to a broader audience. And then again, that tutorial describing the new delivery technology or method for modular RNA delivery also got a great deal of community engagement. Here we see a researcher, Eleanor Sheikey, bring the discussion of this new publication over to another platform where it ended up developing further discussion on her video explanation of this publication. So the next thing I wanted to talk about, the next feature of social media as a tool for medical education, is its low barrier for entry. Really all that's required for engaging and creating med-ed content or commenting on other people's med-ed content is internet access. There are some obvious benefits here. It allows all members of the medical community to contribute to the learning environment, ensuring more diverse perspectives in the content created and the commentary surrounding the content. However, that low barrier of entry also removes a filter that might otherwise prevent the propagation of misinformation. This isn't related to medical knowledge, but it's one of my favorite stories from social media, and I think it does a great job of illustrating the challenge that misinformation plays within social media. Many celebrities have come out on social media in defense of flat earth theory, but none have done so quite as doggedly as accomplished hip hop artist B.O.B. I'm certain no one else has gotten into a tangle with Neil deGrasse Tyson on the subject. The platform and reach social media provides to all comers poses a serious issue by passing the burden of responsibility of parsing out wheat from chaff, truth from lies to individual users who may not be equipped to make those judgments. You know, flat earth theory is one of the more innocuous examples of misinformation that's flourished over the past decade, in large part thanks to its dissemination on social media. Unfortunately, we all know that there are many examples of social media's role in propagating more harmful misinformation. Okay, moving on to decreased knowledge to translation time. Traditional methods of inquiry and assimilation and research have shown that assimilation of primary research into medical practice can take decades. Some well-established numbers are 17 to 22 years of lag time. The foam social media model of information dissemination has the potential to attenuate this lag time, leading to important changes being incorporated more early. The possible downside of this is changes being implemented before there's really sufficient verification of these studies. Okay, that's really all I wanted to say on this. Moving on to the reliance on impact through the dissemination through social media platforms. This component is pretty multifactorial. One benefit is that good content can go viral and have global dissemination and really large impact, reaching a much broader audience than you would in any other setting. This is largely positive. It does have the small takeaway that audience members need to, in different settings from the content creator, need to remain alert to make sure that the content presented is applicable to their patient population. Unfortunately, there are a few discrete challenges that are presented by this reliance on opaque algorithms that determine what content is presented to users. One is a recency bias in social media. Social media platforms want to serve up piping hot morsels straight out of the oven. Content only shows up in users' feeds if it's new, and it makes it difficult to create durable engagement with a particular topic on popular social media platforms. Another issue is that popularity feeds forward to further engagement with a wider audience. People who are particularly motivated, excellent self-promoters, just great hype beasts can secure a larger audience, kind of in spite of the actual quality of their information or their ability as an educator. educator. Additionally, we run into the issue of educators or individuals who are popular within a very specific domain, having a disproportionately large platform to discuss things outside of their area of expertise. See BOB talking about flat earth theory. In some ways, this presents a threat to a backslide into eminence-based medicine, where educators with the most social media clout dictate what educational content is consumed by their followers. Finally, I was going to say indexing on popular social media is poor. The hashtag system that is used on many platforms, it's not regulated. Their search systems aren't nearly as granular as something like PubMed. This issue can be addressed when individuals or groups create their own platforms to organize and index their content. But honestly, that isn't the way that most social media medical education content is really consumed. Brevity, that's another multifaceted feature of social media's utilization in medical education. Brevity is present as an absolute in the design of some forms of social media, most famously Twitter's 140, now 240 character limit. Brevity is also imposed by how users preferentially engage with shorter, more concise posts on social media. Although the data from NewsWhip, a social media analytics company that I have here, does show that social media users do maintain a certain penchant for more long-form content. To that end, I would also like to mention that brevity is not universal across all social media platforms. Blogs, wikis, and social media frequently present their content in much longer form. So this has some benefits, this brevity. It makes the content more approachable for learners. It also puts pressure on content creators to be as concise as possible with their presentations. The bad side is that some topics really do warrant more in-depth, lengthy discussions in order to really appreciate the depth and the breadth of the topic. Anonymity poses a major challenge within social media as well. It's inversely related to accountability. It erodes professionalism, real good faith efforts at discussion. And for this reason, within the medical education community, professional identification in social media is very strongly encouraged, however, not universally adopted. The other issue is that even if a person identifies themselves on social media, the disclosure of conflicts of interest remain voluntary on these platforms, and it's hard to identify what influences are going into every single discussion. Okay, and then this last feature, the assessment of learning outcomes within social media, I think is immensely under-recognized. Scholarship in medical education has dealt with significant challenges in identifying meaningful outcomes to track, as well as just collecting the data on these selected outcomes. That's used to actually determine the efficacy of different interventions. Interactive modes of FOMED offer built-in methods for pre and post-test evaluations to assess how well learning objectives were addressed through the content. Here we see examples of pre and post-module questions, as well as a link to more robust post-test evaluation and just evaluation of the content. Additionally, social media users, specifically neurotic Redditors, have created predictive models for individual board test scores in the past, based in part on what educational materials an individual used to prepare for their board exams. The models are created by collaborative efforts from Reddit's Step 1 MedEd community and the willingness of the community to freely volunteer their data on their study habits and test performance. I think that further studies can really take advantage of these latent medical education communities by engaging with them and really collecting whatever data they can regarding their study habits, their performances on different specified outcomes. So those were the unique features of social media I really wanted to hit on. There's definitely a few other things like asynchronicity that's present on these platforms. Don't really have the time to get into everything here, but some takeaway points here is that social media is a powerful tool for the creation and dissemination of information, it can create these very robust collaborative communities, and that might be the most powerful feature of social media for medical education. And then I think that there's some untapped potential for quantifying the effect of educational interventions. So with all that said, I'd like to thank everyone for the opportunity to give this talk and to share a few memes on the Flat Earth community. I'd especially like to thank Dr. Cow and the Teaching Physician Pathway, Dr. Costco, our chief resident, and the unwavering support from my fiance, Kelly. Happy to answer whatever questions come at the end of Dr. Ahmed's talk, but I'd like to welcome him on over to the stage here.
Great, Dr. Garza, thank you so much. That was a fantastic talk, and I'm sure we'll have some questions a little bit later. We can go ahead and stop share, and we'll switch over to Dr. Ahmed. And again, a reminder, if anyone does have any questions, feel free to send them to me, and we will address them here in just a little bit. But in the meantime, looks like, yep, slides are coming through great. Go ahead, Dr. Ahmed.
All right. All right, good morning. I hope everybody can hear me. I want to thank Dr. Hickman for the warm introduction, and I want to congratulate Dr. Garza for his wonderful talk this morning. My name is Mohammed Ahmed, and this morning I'll be talking to you about medical volunteerism, some of the challenges and some of the opportunities looking forward. I have no financial disclosures. So to frame this talk, I'll start with a personal story. This is the world map categorized based on the 2020 gross national income per capita, meaning the amount of money earned by citizens of each country per year. For your curiosity, in order to qualify to be called a high income country such as the US, that number had to be higher than about 13,000 US dollars per year. And for countries categorized to be low income, that number was below 1,000 US dollars per year. So for the first 2 decades of my life, I grew up in Ethiopia, right there in the Horn of Africa. I was witness to and a recipient of many aid efforts by multiple aid organizations. The UNICEF emblem is still pretty vivid in my memory. In my time there, the prevailing notion in the communities in which I lived was that Western medicine was always better medicine. And in the last decade, having been educated and now training in Western medicine, I wanted to take this opportunity to shed maybe a different vantage point on the notion of humanitarian aid, volunteerism, especially in resource-poor regions. So to start this talk, I want to invite you to imagine a scenario with me. So a foreigner sets up a clinic in your city. He's never been to your community, does not speak your local language. He will leave in a week and is likely to never return. He claims to be a physician in his home country, but he refuses to work with physicians or other health professionals in your local healthcare structure. My question to you is, would you see this person if you had other choices? So my goals this morning, at the end of this talk, I would like for you to understand a bit of the history and context of aid and medical volunteerism. We'll go through some of the sectors in which it is practiced today. We'll identify some problems that plague the system currently as it is, and then we'll analyze opportunities for improvements looking into the future. And then we'll summarize this talk with a few key points that I would like for you to take away from this. So starting with a historical perspective, medical missions, mainly in the 1700s and 1800s, accompanied missionary work that was meant to spread religion and support colonial efforts. Primarily at the service of the colonial government, these work by garnering goodwill from local communities, thereby supporting their efforts to proselytize as well as occupy further territories. And around the same time, we hear names like David Livingstone traveling around Southeast Africa. Moving a little bit forward to the 1900s, we see a little bit of shift in that paradigm towards more long-term engagements. We hear of people like Albert Cook in Gabon and Albert Schweitzer in Uganda, who essentially set up hospitals in which they'll essentially serve their entire lives. We see some of the first non-governmental organizations or NGOs being set up, like the Red Cross. And we see a shift of more from religious type missionary work to more secular professional work. The main turning point is the Second World War, when the major superpowers realized that cooperation is really the way of the future, mainly economically. And we have the setup of the United Nations, and thereby also subsidiaries like the World Health Organization, which is really meant to tackle global issues like pandemic and epidemic. And then going further along, we have more NGOs being set up, like Médecins Sans Frontières, which now are more involved in regional issues, because at this point, the World Health Organization has become pretty big, and because of the bureaucracy, it has become pretty slow to address certain regions pretty effectively. And around the turn of the millennium, really the last 2 to 3 decades, we see a lot of the ethical concerns kind of come to the surface. They're all there throughout this time, but we're talking about them more, and we're trying to figure out better ways to do this. Because this is such a broad topic, I'm going to try and focus it a little bit this morning. So in my definition of medical volunteerism, I'm referring to individuals who are not employed by an organization, volunteering that is done not in the setting of disaster relief. And I want to tailor this talk as much as possible for practicing and in training physicians. So next, we'll go through some of the sectors in which we see volunteering happening today. Using a top-down approach, we'll start with the intergovernmental organization, which are the biggest and most well-funded organizations. These include your classic United Nations, World Health Organization, and further on. Then we have the non-governmental organizations. These are usually started by one individual or multiple, and have their own specific mission which they're trying to accomplish. They can be either advocacy-based NGOs or actionable NGOs. And again, examples here include the Red Cross, Médecins Sans Frontières, and so forth. Then we have for-profit organizations, which still do a lot of humanitarian work around the world. And these work by marketing certain aspects to participants, including skills, tourism. Then we have academic institutions, which are also pretty active in this space, and usually take the form of 2 particular flavors. Either it's pure volunteering by partnering with one of the above organizations, or is through global health electives, which are not technically volunteering per se, but because they involve some of the same elements, they are prone to some of the same issues. And then we still have faith-based organizations which are active in the space. And then we also have private parties. Next, we'll go over some problems and issues that are kind of pretty common in this system and give a little context further on. So in 2010, a group of surgeons got together and published this narrative review of some of the most common issues that they saw in their multiple missions across many years and in many countries, and aptly titled it The 7 Sins of Humanitarian Medicine. These included leaving a mess behind, having mismatched resources to local needs, failure of different organizations on the ground to cooperate, having no follow-up plan, allowing politics or training to influence the services rendered, going where you are not wanted or needed, and doing the right thing for the wrong reason. Over the next few slides, we'll describe some of these issues a little bit more in depth, and again, give you a little bit of context to help you picture this in a real way. So I'll start with the first one, which is leaving a mess behind, which is perhaps the most obvious antithesis to humanitarian aid and medical volunteering anywhere in the world. This includes two aspects. The first is doing a poor job, and secondly, doing an incomplete job, hence laying on some of the work to the local healthcare system, which is already burdened and encumbered. And to nail the point home, I'll use the case example of Operation Smile. So this is an organization that was set up in the 1980s. Its main mission was surgical repair of cleft lip and cleft palate in children around the world. As one of the first organizations to ever do this, it was pretty popular and garnered a lot of funding in the beginning. Problems came up in the 1990s when cases of some fatalities came up, most famously in China and in Kenya. And these were determined to be largely preventable deaths. The problem here was a loss of focus, whereas they were more concerned about the volume or the number of procedures performed, which directly fed into their marketing strategy and hence their funding. They lost sight of the bigger picture. There were also issues with post-op complications. And there was a lot of reports at the time about them leaving without completing part of the work, hence patients needing further care at their locality and sometimes even having to be flown out to other places to complete their care. The next issue is that of mismatched resources and demands or infrastructure. And I'll use a couple of examples here. The first is one of mismatch of equipment. So taking the example of that picture, taking a particularly advanced piece of equipment like a CT or an MRI machine in a place without the provisions of the infrastructure to run that equipment, such as, for example, stable electricity, the housing, the training needed to read those radiographs or imaging, the training needed to service that equipment, and replacement parts as well. Without all those provisions, use of that resource is very limited and should be reevaluated whenever we're thinking of donating such equipment. And then the second issue is that of transferring skills. And what I mean by this is, so what many organizations would do is try to train local workforce in some advanced procedures, for example. Take an example of endoscopies. They would train local communities without the provision of that equipment staying there for them to use it. So either the organizations that did this training at the end of their time would take the equipment with them and go to the next site and kind of repeat this training, or they would leave the equipment and then tell the locals that they couldn't use it until somebody else from the organization came to their place at the time. Both cases are issues of essentially mismanaged resources, and we can put these resources to better use if we just kind of think about it a little bit further. Then going where you are not wanted or needed. This is probably the biggest bucket of foibles, containing a lot of things, but it goes off the premise that not every volunteering opportunity is suitable for the participants. So skill matters. If you do not possess the particular skill that is needed in a particular location, then that is clearly not the place to go. For the example of the cleft lip repair, as a surgeon, if a bulk or part of your practice does not entail cleft lip repair, then going to a place to do that work is kind of problematic. Language matters. It is the main form of communication and it breeds trust. Culture matters. Having enough humility to accept that you may never understand some aspects of a whole people's culture is important. Costs matter. Critically assessing whether the costs used to fund a volunteer mission would not be better utilized on the ground. Having those assessments is important. And then intent matters. So whenever we're doing this type of work, we always have to assess our motivations. And if being in service of people in need is not atop those priorities, then that's also clearly an issue. Next, we'll change gears a little bit and go over some of the opportunities for improvements in this system and some key solutions that we can enact. And again, I've divided this into 4 main categories that I'd like to focus on. The first one is, I want us to reframe our mindset. I want us to go from an old system that mainly entailed taking a raw number of bodies from one location and then transferring them to a different location to perform a certain number of tasks, to a goal of transferring skills, transferring techniques, and transferring knowledge, which can be propagated in those local communities for their benefit. And ways to achieve this, we have to be able to embrace the local expertise. They are the best architects of their own solutions, and we need to be able to empower them most. We have to be able to take a back seat. Again, the communities which are on the ground and local are the ones that are going to be there the longest. They're the ones who are going to be able to effect the most amount of positive change. So in effect, we have to support them first. And then we have to be able to facilitate training for the local talent and invest in the local talent, whether it's education outside that immediate environment or advanced training in abroad the country as well. The concept of longevity is a pretty simple one, but building relationships and having that therapeutic alliance takes a long time. These solutions take a long time, and if you are to have any positive impact in that community, it's going to require quite a significant duration. And again, using a case example from my backyard, we'll take the example of the Addis Ababa Fistula Hospital. This is a hospital that was founded in the 1970s by an Australian obstetrician by the name of Catherine Hamlin and her husband. It was the first hospital dedicated to obstetric fistula care, a common problem after birth for women in the country and in the continent. And it has remained in the community for the good part of the last 4 to 5 decades. It has become a center of excellence, which has trained multiple practitioners. And it has become a staple in the community, very well known, and that gets a lot of referrals from even other countries. It's kind of an example of how being embedded in that community and having that long-term relationship can lead to a positive impact. And then I mentioned this prior, but this issue of redirecting costs to where they'll be used best. So if we do a little math, we take the numbers from 2010, they estimated that the cost per volunteer to go on a regular medical mission would be about $3,000 US. And if we multiply that by 10, which is kind of an average size for a group of people going, and the duration, let's say 10 days to 2 weeks. So if we're spending $30,000 for one group, and you can see that there will be multiple groups kind of switching back and forth in one place, the costs add up pretty quickly. In a significant portion of the world, 50 to 100,000 US dollars is a significant amount of money that can have pretty significant impact on A, building better infrastructures, B, acquiring better equipment, and C, and importantly, paying for or subsidizing local salaries of multiple folds compared to the 10 people that we're trying to fund. And it goes off again from the basic understanding that poor health is a function of poverty, and it's usually a pretty direct linkage. So things we can directly do and actions we can take to invest in the local infrastructure and support the local salaries will have a pretty significant and direct impact on improving health in that region. And lastly, this concept of training and preparation is ubiquitous. You know, understanding global poverty again is an important concept and understanding its consequences in the world. Having a grasp of the local geopolitics in whatever area we're trying to render services is important. Having training in cultural competence and acknowledging some of the cultural differences is essential. And then having in mind ethical considerations, mainly that whenever we are going into these communities, it's usually the fact that we are sort of their last resort and they don't really have much other choices. So we have to really reflect on that fact and acknowledge ourselves, our scope of practice, and our standards compared to where we would be practicing whatever home we're coming from. Now, I'd like to put this sort of all together to have these takeaway points. So again, I want us to again reframe the goal of medical volunteerism, humanitarian aid, towards a goal of sharing skills and that of collaboration, more so than that of doing certain tasks in a particular place. Long-term solutions will always yield better outcomes than short ones. As the participant, being selective of the opportunity is better based on the skill set that you bring. And then training is always essential before embarking on any type of experience. And now, before I end this talk, I would like for you to reimagine this case with me one last time. So this time, another foreign physician sets up his clinic in your city. He usually comes every year during spring and stays for a month. He does not speak the local language, but he hires an assistant who translates for him. In addition, he works with 2 local physicians in the same clinic. He's a retinal surgeon and shares his time performing cases and teaching ophthalmologists. My question to you again is, would you see this person? And with that, I would like to end this talk and make acknowledgements to Dr. Frazier, Dr. Costco, and all our APDs, Dr. Matar for providing me some content to do this talk, my fellow house staff, and the chiefs. And I want to thank you, the audience, for your attention this morning. Thank you.
Dr. Ahmed, thank you so much for the fantastic talk. And thank you to both our speakers today. I see at least one question in the chat we'll get to in a moment. Again, please feel free to send any more to me as we go. Before I start asking these, let me just go ahead and throw up the QR codes for everyone before I forget. Hopefully you can see that. All right, Dr. Ahmed, again, thank you so much for a very important topic. You know, you have a lot of organizations of varying types and hierarchies and governmental control or non-governmental control, and certainly academic institutions like ours is one of those. How can we best enforce best practices to avoid medical tourism and have an effective change on a trainee level when we have such limited time, especially for our trainees to participate in this kind of endeavor?
Great question, John. Thank you. So really, I think it's kind of a complicated answer, but I'll try to simplify it. So first, I guess the thing to ensure is, one, that we're working with an institution that has done this for a long period of time. And that's the case here at WashU, which is great, and has those relationships with local communities across the world to, again, effect those changes. So that's kind of basically the pre-study phase you would have to do as a participant if you didn't know the organizations, which we do at this point. The second thing is sort of analyzing what our impact would be in that situation. So there is many different types of aid missions and electives. There is, electives that entail a lot of procedural aspects. There is electives that entail exposure to different kinds of, whether it's, and I'll use the example of infectious diseases for pretty common, of exposure to different types of communicable diseases and their treatment. So we have to understand sort of what our impact can be in that setting. As a trainee, I think we should expect to have the same level of practice and scope as we would here at home when we're treating anybody in the ICU or on the floor. There might be a little bit different responsibilities based on what is needed, but I think if we follow sort of the standard that was already set at home and having supervised practice as we do here, and doing, again, what's right for the patient, I think we can sort of start off the right foot. But other things, again, intentions are not always the same as outcomes. And we have to be aware of that and go in with that mindset and be knowledgeable about some of the issues that exist.
To that end, and this may just be a deficiency of my own knowledge, are there independent review organizations that we can engage or that are out there to assess the efficacy and impact of some of these volunteer organizations?
So there are some, but a lot of it is still done by the organizations themselves. They will have a part of the organizations that essentially is dedicated to internal review, which is sort of a little biased because, again, it's based on people who work for the same organizations. But there are, yes, external organizations which do review. And it is important to do that review, and it hasn't really been done for quite a long time, to do research and to assess some of these impacts and assess, the efficacy of all this work.
I have a question from Dr. Spencer, and honestly, it may apply to both of you. She states, I'm wondering whether there are opportunities to use all that we learned about maximizing efficacy and impact on social media to enhance medical volunteerism via online education, funding campaigns, and collaboration with communities. Are either of you aware of work in that area?
Sure, I could speak to one component of it, and that is really the process of creating and posting med-ed content on social media creates a community by whoever engages with it. The question is that community kind of ephemeral or is it durable? And if it's durable, what are the ethos of the community and the focus of the community? I've seen some people who get a community based off of a particular physician's Twitter handle. They end up using the community they've created to direct their followers to a specific cause, or to creating, the example of the Neff Madness sort of tournament of medical education, volunteerism sort of talks. And I can definitely see a way where if you create these durable communities, you can, I don't want to say repurpose, but you can redirect the efforts and the goals of the individuals within the community.
And I'll add on to that. I think, yeah, a lot of these things help. There are, if you do a simple Google search about volunteer organizations or causes, a million things will pop up, whether it's for funding, different opportunities in which to get involved. I think, honestly, the issue now is more a vetting of those particular websites and organizations that are, online, because they will all sort of try to market the same things and try to offer the participants a lot of perks because it's a competitive marketplace, even in the volunteering arena. So the issue will become sort of sifting through that and assessing which ones are worth it and which ones may not be.
Thank you so much. The next question ties into that a little bit, and it's directed for you, Dr. Garza. Siriyantra asks, what are your thoughts on docs including tweets or my opinions, not medical advice, and whether that should be the standard for #MedEd, especially since there's no reliable way to fact check any of the information disseminated on Twitter other than crowdsourcing?
While I think you can water down maybe the impact of the message you're trying to send, I think that should be the standard. I think that we can't be speaking in terms of absolutes here, and these sorts of disclaimers need to be present at the front end of these sorts of statements. I think that while audience members who in the community that receives these tweets always need to be taking them in with a grain of salt, I think that we need to be presenting this information with the same professionalism, with the same sort of nuance that we would if we were consulted on a specific question or if we were giving a talk on a particular topic, in the real world.
Another question I had, in what's an increasingly expensive market for testing materials and question banks and sort of more traditional model, as we move away and maybe towards more pass-fail of some of these traditional testing and resources, do you anticipate more of a slide towards using social media as our primary source of information, or do you think that's still not going to be the norm?
So I think that the major issue with that and the major barrier to that is the topic selection and indexing system with social media platforms and free open access medical education platforms. A lot of the times the topic selection is based off of topics that are really, hot at the moment, will get a lot of engagement that people are particularly interested in, and things that are maybe less interesting, less engaging, but still are necessary for a strong foundation of medical education, really don't get that same sort of attention on these open access sort of tools. This does exist, but more comprehensive tools do exist and resources do exist, but they're kind of more the exception rather than the rule. So I don't see open access medical education completely replacing textbooks or more traditional question banks in the immediate future. But I do see, and there isn't any data for it right now, at least I'm aware of, but I do see a general shift into learners, whether that be undergraduate medical students, graduate, residents, or lifelong learners, using these free open access medical education resources more frequently, and it taking up more of their time whenever they're doing their research.
All right. Well, we're just about at time. I want to thank both of you again for fantastic talks, and really all of our senior residents over the last 4 weeks. I know I speak for myself and our whole program that we are just so proud of the work that you've done through all your years here and the talks especially. So congratulations to you and all of our speakers. It's been an absolute pleasure hearing from you. A reminder again, if you want to check out any of these talks or you missed any of the last couple of weeks, please come to the Department of Medicine website or our YouTube channel. And please again, join us next week. We're going to have an update on COVID with our very own Dr. Stephen Lawrence. And so you're not really going to want to miss that one. Thank you all again and take care.
Thanks, John.
Thank you.